Hello, everybody. My name is Professor Ayman Abul-Majd, Professor of Cardiology at the Azhar University, Cairo, Egypt. Today's topic is refractory angina, which is a very important and hot topic. As we know, symptomatic coronary artery disease is a very widespread disease all over the world. And if we look at this slide from the top, it says out of 6.2 million patients with coronary artery disease, the majority will get medication and lifestyle modification. Some patients will need surgery. Others will need percutaneous intervention, which is about 1.2 million patients per year. However, at the bottom, we see that about 80 to 200,000 patients with symptomatic coronary artery disease are not amenable to intervention, whether surgical or PCI. These are termed refractory angina pectoris patients. This is defined as a chronic condition of reversible myocardial ischemia in the presence of coronary artery disease, which cannot be controlled by optimal medical therapy, percutaneous coronary intervention, or CABG, surgical intervention. They represent about 5 to 10% of stable coronary artery disease, and in the United States account for 50 to 100,000 new cases per year. In Europe, they account for 20 to 30,000 patients in the European Union. Now, the most common reasons why further revascularization procedure is not possible is first, unsuitable anatomy, such as diffuse coronary artery sclerosis, or one or several previous surgeries and or multiple previous PCIs, percutaneous interventions, which exclude further benefit or possibility of further revascularization or may carry excessive risk to the patient. Another reason is lack of graft material, impaired left ventricular function in patients with previous CABG or PCI, extracardiac disease, which increases perioperative or postoperative morbidity or mortality, such as general arteriosclerotic disease, renal insufficiency, carotid stenosis, and pulmonary disease. Age, often in combination with the above-mentioned factors, is another important reason. Medical therapy, as we know, is commonly prescribed for angina pectoris. And we know all these medicines, the beta blockers, which decrease heart rate and contractility, calcium channel blockers, nitrates, ranolazine, trimetazine, nicorandil, fasudil, which is a Rho kinase inhibitor, antiplatelet agents for anti-inflammatory activity, angiotensin-converting enzyme inhibitors, and statins. Obviously, all angina patients will go through all these medicines. So when we say refractory angina, we mean patients who have had all trial of proper doses of all these medications, yet they continue to have symptomatic angina pectoris. Now we have new approaches for these patients. The first is the coronary sinus reducer. And this is a study looking to assess the safety and efficacy of the coronary sinus reducer in patients with refractory angina. It's called the COSERA trial for treatment of refractory angina. The reducer is a stainless steel balloon expandable stent. It is hourglass shaped. The mid portion diameter is 3 millimeters. At the ends can reach a diameter of 7 to 13 millimeters using a balloon inflation pressure of 2 to 4 bars. It is a simple procedure introduced in the coronary sinus through the right internal jugular vein, and it creates controlled narrowing to modulate flow and elevate coronary sinus pressure, which increases endocardial perfusion, providing the relief of ischemia and angina. And this is shows the implantation of the reducer in the coronary sinus. The mechanism of action is that the reducer creates a slight increase in coronary sinus pressure, which results in the dilatation of the capillaries and arterioles and improves perfusion of the ischemic subendocardial myocardium. In the setting of obstructive coronary artery disease, it increased coronary sinus pressure and will lead to redistribution of collateral blood flow from non-ischemic into ischemic territories of the myocardium and redistribution of arterial blood from the subepicardial to subendocardial vessels, which with normalization of the endocardial-epicardial flow ratio and redistribution of arterial blood, which significantly reduces myocardial ischemia. And the results of the trial shows that now in the trial, it's very important to understand they divided the patients into two groups, a sham group and an active group. An active group is that all these patients will go into the cath lab and they will undergo a procedure. The active group is the group which will actually have a coronary sinus reducer implanted in the coronary sinus. The sham or placebo group is a blinded group that will undergo the procedure but will not receive the coronary sinus reducer. And this is called a sham procedure. Sham meaning they go into the cath lab, they have a procedure, but they don't actually get the coronary sinus reducer. And we can see that in the active arm, which is the blue, there's a significantly greater improvement in the percentage of patients having more than 2 class improvement in angina symptoms, indicating that the results are due to the reduced coronary sinus reducer and not due to a placebo effect on the psychology of the patient. This is very important, and we must remember this because we will see it in many studies in the future. In summary, the COSERA trial evaluated the coronary sinus reducer as a new therapy for patients with refractory angina. Reducer implantation was significantly better than a sham intervention to improve angina symptoms in patients with advanced coronary artery disease unsuitable for revascularization and treated with optimal medical therapy. The improvement of more than 2 angina class, which is the primary endpoint, occurred 2 to 3 times more frequently in the reducer group, demonstrating a clinically meaningful and significant difference with a p-value 0.024. Based on these findings, percutaneous transvenous implantation of the coronary sinus reducer is a safe and effective treatment for patients with refractory angina not suitable for coronary vascularization. The percutaneous transmyocardial laser revascularization, TMR, has also been performed percutaneously using a less invasive catheter-based approach that is referred to as PTMLR. It's a catheter-based laser fiber optic system which is introduced through the femoral artery through the aortic valve into the left ventricle. The laser-made channels in the myocardium are created from the endocardium towards the epicardium, guided by fluoroscopy and simultaneous transesophageal echocardiographic monitoring. It produces controlled injury to the epicardial coronary artery, chorda tendineae, bleeding into the pericardial sac, and neurological complications are possible, although they occur in a small percentage of patients. In this surgical procedure, after left lateral thoracotomy, this is the surgical. This procedure can be done either surgical or percutaneous through the femoral artery. Either way, you produce 1 millimeter full-length holes in through the ventricle are made with a laser on the epicardial surface of the left ventricle, creating 10 to 50 small channels from the epicardium to the endocardium, 1 centimeter apart from the base to the apex, and then in other lines, 1 centimeter from each other, creating a total of 20 to 40 channels. These channels and the capillaries that grow out from them provide a way for oxygenated blood in the left ventricle to nourish the myocardium. This concept was studied in the DIRECT trial, and this was a randomized, again, placebo-controlled, that is, sham-controlled prospective trial, including 298 patients into 3 treatment arms. The placebo procedure, which, as we just mentioned, they go into the cath lab, they undergo a procedure, but they don't actually have any laser treatment. Then the second group are low dose, where they go into the cath lab, they undergo the procedure, and they have 10 to 15 channels created. And the third arm are the high dose. The patients go into the cath lab, they undergo the procedure, and they have the endomyocardial channels created, but here they're creating 20 to 25 channels. So we have 3 groups of patients. One group goes into the cath lab but does not have any channels created. The second group goes into the cath lab and has 10 to 15 channels created. And the third group go into the cath lab and they have 20 to 25 channels created in the myocardium. What did they find? The results were similar for all treatment arms, representing a large placebo effect. This demonstrated that there was actually no therapeutic benefit on patient survival, angina class, quality of life, exercise duration, and this therapy accordingly was promptly abandoned. And this is very important because we have to remember the very strong, powerful effect of a placebo on patients' symptoms. Next is the ESMR, which is extracorporeal shockwave myocardial revascularization, and this is believed to be a breakthrough in management of refractory angina. The treatment is performed using a special generator that produces low-intensity shock waves, a kind of sound waves similar to, but of lower strength than extracorporeal shock wave lithotripsy that is used in the treatment of kidney stones. These waves stimulate the formation of new blood vessels in the heart. The shock wave schedule consists of 3 20-minute sessions per week over 9 weeks. And it is being evaluated in large-scale trials currently. Now, more recently, there has been a re-evaluation of our understanding of refractory angina and its relation to ischemia. The prevailing paradigm was that it is an ischemia-centered approach. However, the relation of ischemia to angina is actually more complex, and it ranges from ischemia without angina, which we call silent ischemia, up to angina-like pains without ischemia, which is termed the sensitive heart. Therefore, ischemia documentation is not necessary to have angina, which may be due to triggers and final perception of afferent neurologic signals from the heart as evidenced by placebo improvement in symptoms, as we just mentioned. So the new paradigms is that coronary microvascular dysfunction is believed to play a major role and occurs in 37% of patients with angina and no coronary artery disease. There is impaired myocardial blood flow, but this does not necessarily lead to myocardial hypoxia. With hypoperfusion, the ischemic threshold may be elevated by metabolic adaptive responses, and therefore there could be ischemia, but no angina. Cardiac nociception, which is the sensation of pain. Nociception occurs at the myelinated and unmyelinated fibers in the cardiac septate, forming the cardiac afferent sensory nerves. Ischemia releases adenosine, bradykinin, substance P, histamine, prostaglandins, and potassium, triggering action potentials causing nociception, that is the sensation of pain, and may modify the ischemia threshold, converting ischemia into anginal pains. From physiology to perception, we can say that painful stimuli travel through sympathetic or vagal afferent nerves to the thalamus. PET studies show that cortical activation in the thalamus is required for pain perception, and that this is blunted, diminished in cases with silent ischemia. So when you have patients with large areas of ischemia and they have no angina, this is most likely due to blunting of the cortical activation in the thalamus. Microvascular angina patients have increased thalamic activation relative to patients with coronary artery disease, suggesting that the origin of pain is actually central. These are the basis for new therapeutic modalities. This diagram shows the relation of the thalamus and the placebo effect, and we will talk about the various spinal cord stimulation, cervicothoracic ganglion, stellate ganglion blockade, and transcutaneous electrical nerve stimulants, TENS. Novel therapies, viral transfer-based angiogenesis. The aim is to create new vessels in the myocardium to feed the myocardium and improve ischemia and improve chest pain. Vascular endothelial growth factor D and fibroblast factors have been utilized in trials to promote angiogenesis using NOGA, which is a mapping-guided intramyocardial injection catheters. In studies on a small number of patients, they showed improvement in angina class at 3 and 12 months. Again, they were compared to placebo, so they are offering promise for the future. Fibroblast growth factors 4 in the adjuvant trial also showed improvement, especially in women, though the improvement was less in men. However, larger trials are awaited. As I mentioned before, these are novel therapies studied now on their way for larger scale trials in the future. The next is cell-based angiogenesis, the first of which is CD34+. CD stands for cluster of differentiation cells, are strong stimulators of angiogenesis. They are injected via NOGA, which as we mentioned is mapping of the myocardium or intracoronary in trials, and they have shown promise for improving symptoms and exercise time duration at 3 and again at 1 year. Number 2 is CD133+. These cells also show promise in ischemic cardiomyopathy patients, improving angina, and they actually improve perfusion as well as cardiac function. Very promising for the future in this very difficult to treat group of patients. The next is treatment for neural processing. Much research is going on in this field right now, which is transcutaneous electrical nerve stimulation, TENS. This consists of low-intensity currents via chest electrodes, which improve pain by stimulating afferent sensory fibers. Again, this is early and it awaits more proof of the concept. Next is the spinal cord stimulation. This consists of multipolar leads and a pulse generator. The leads are inserted from the epicardial space at thoracic 6 and 8 and are advanced to cervical 5, to thoracic 2 segments, to the afferent myocardial sympathetic fibers, which synapse with sensory neurons and stimulate and are stimulated to cause paresthesia in the area where the patient feels the angina pains. In other words, they go with the leads. They ask, first of all, they ask the patient, where do you have the pain? The patient says, in this area of my chest. They locate this area and they stimulate it with the multipolar leads and the generator to improve the anginal pains. And it was found to improve pain and also to improve myocardial perfusion. But unfortunately, this needs further refinement because there's a 30 to 40% very high complication rate. This is a diagram of the spinal cord stimulation, the power source, the electrodes at the stimulation site, and the vertebral column where the pulsations are given. Stimulation typically administered for 1 to 12 hours, 3 times. This is the therapeutic mechanism appears to be alteration of the anginal pain perception. Next is SENS, which is subcutaneous electrical nerve stimulation. Subcutaneous electrical nerve stimulation, again, at the site of pain in the chest. This has been performed in a small number of patients, again, awaits larger studies. Sympathectomy, which is left stellate ganglion blockade, local injection of the anesthetic at the ganglion at the level of the C6 vertebrate. It provides effective relief of pain for 1 to 4 weeks. Also, there is surgical sympathectomy, and these have been shown effective, again, in small trials, awaiting larger trials to prove their true significance. In conclusion, end-stage angina pectoris refractory to conventional medical therapy and not amenable to either CABG, surgery, or PCI represents a truly desperate and frustrating condition for both the patient as well as the physician. There is no suggestion that any of the alternative treatments for refractory angina may improve prognosis, although they can improve symptoms and quality of life. The choice of treatment should be mainly based on a careful assessment of the balance between the benefits for the disabling symptoms of the patients and the risk associated with the different treatment options. Thank you for your attention.